So it's not an hour for each of us? Oh. All right. Well, thanks for coming tonight, and I'm proud to come talk to you about the UNC experience with deep inspiration breath hold for left breast treatments, and also talk a little bit about the background about our recent studies we've come out with and a study that we've just completed. So I want to give you a quick overview that radiation therapy related cardiovascular disease has been studied by our team of physicians and physicists for over 20 years. UNC has been very active in monitoring cardiac toxicities in thoracic radiotherapy as well as breast cancer patients. And we have been treating with a DIBH or breath hold technique for over 7 years. So in collaboration with Vision RT, UNC recently completed a study to assess DIBH cardiac toxicity using SPECT imaging. We'll talk about that a little bit later. So as an introduction, we know that the heart is an organ at risk in radiation therapy. And we know that radiation-induced cardiovascular disease, especially for women with breast cancer, has been a concern for decades. But there's been some studies out there showing that yes, this does occur, but we know that more and more that patients are being treated with systemic agents that may be cardiotoxic as well. Things as anthracyclines and trastuzumab have been given more and more with breast cancer patients. And we know that the clinical manifestation of cardiovascular disease sometimes can take 10 to 15 years before it shows up. Usually, in a lung cancer patient, this may not have been a driving concern, but as breast cancer patients are diagnosed earlier and earlier, that the cardiac toxicities is becoming more apparent in the minds of our physicians. A 2005 study of 42,000 women in Europe found that a rate ratio of post-RT heart disease to be 1.27%. So for every patient that was not treated with radiation therapy that developed cardiovascular disease, 1.27 women developed it that were post-RT. So a 27% increase in the incidence of cardiovascular disease for post-RT. So not just the high dose, but we know that the low dose of the heart can also be an issue. So long-term follow-up suggests that the average heart dose is also related to coronary events. A study of 2,000 women irradiated for breast cancer in Europe between 1960 and 21, almost a 40-year follow-up, found that the rate of cardiovascular events increased with a mean heart dose by 7.4% per gray. So even the mean heart dose is typically low, can also lead to cardiovascular disease. So something happens 10 or 15 years down the road. Do we have an earlier indicator for what might be that might happen here? So what we've been looking at UNC is using cardiac perfusion SPECT imaging to try to observe any perfusion changes in the heart 6 months post-RT. And we have extensive experience with that. We've followed 114 left-sided breast cancer patients. Post-RT SPECT imaging observed a 27% rate of perfusion defects after 6 months of radiation therapy. In the image that you see at the bottom of the screen here, we have a patient on the left, which is pre-RT and post-RT, with the tangential beam edges shown in 2 lines. And what we can see is that there's a defect right here in terms of we no longer see the SPECT counts right there. So this perfusion defect right here was directly caused by the radiation 6 months afterwards. So what is one way that we can try to combat this or overcome such a thing? We've been using deep inspiration breath hold for such a thing, and it is one technique that can help reduce the cardiac dose. First, it moves the heart inferior and posterior from the treatment zone. As we can see from the free breathing and the deep inspiration breath hold image, we can see how that heart is pulled down when the patient takes a deep breath. It also helps reduce the tumor bed motion, decreases the heart dose because we're pulling that heart away from the radiation field. And as a side benefit, we've also decreasing the lung dose that the patient is getting because we've increased the volume. We're going to drive down indicators such as our mean lung dose. So our experience, we've been using Vision RT since 2009. We have a Siemens Artis and an Electa Versa unit that have been equipped with the Align RT camera systems. And going back 2 years, I found that we have treated 150 plus left-sided breast cancer patients using DIBH. So I just want to show you a quick example of what a plan looks like. So we take an example plan at free breathing and deep inspiration breath hold. What we do is we plan to achieve similar breast coverage. This patient that I'm about to show was treated 50 gray and 25 fractions, and we can see that for the breast coverage, the heart is outlined in pink. Hopefully that's showing up for you. But you can see how that heart is really pulled far away from the radiation field, but we're achieving similar breast coverage in this picture. So what this shows us is one of the benefits of deep inspiration breath hold. that for this patient, the mean heart dose went from 3.8 to 1.3 gray, and the max heart dose decreased from 48 down to 3.6 gray. So looking at some of the studies earlier, we're believing that this could really reduce the cardiac toxicity. I want to make a quick important point about the importance of DIBH positioning. So surface tracking is a surrogate for the breath hold position, and there's many different systems out there that claim to be able to track breath hold position. But AlignRT will monitor the patient's surface in real time. We had experience in the past with other systems such as pressure belts and strain gauges, and depending on how you apply that to the patient, you're going to get a different signal out every time. And I observed this being changed on a daily basis, how tight the respiratory belt is on the patient, et cetera. And also interfacing with the machine, it was always a manual override by the therapist would actually have to stop the beam. So we found that a system that would not only track the surface but automatically turn off the beam was much more advantageous. And I wanted to point out a great paper from the folks at Moses Cone, which asked how important is a reproducible breath hold position. So what this paper looked at was they would plan on a DIBH scan, they would plan on a free breathing scan, and they would basically copy the breath hold and say, let's say this patient we accidentally treat this patient free breathing. Does the coverage decrease? And then they also looked at if this patient only takes half a big of a breath, they would make a mid-heart position. And they basically would do 3 plans for each patient looking at breath hold, free breathing, and a mid position. And they ask, let's say this patient doesn't take in as deep a breath, is the plan still just as good? What they found that even for a partial breath hold, they found a reduced heart dose for all of their patients that they studied. So yes, reproducible breath hold is good, but if the patient can only take so much of a breath hold in, we're not going to be mistreating them. We're going to be just as good, if not better. So in our experience, a majority of our patients were able to breath hold for 15, 20 seconds plus. If you get some patients in that are well versed in doing yoga, they can really astound you with how well they can hold their breath each time. We found that respiratory coaching can be a great asset for some patients. We often have a QA day before treatment starts where we get the patient on the table and just go through some coaching tricks with them and basically talk them through it, and I think they have really taken to that well. A study from UNC in 2014 looked at 50 patients, and we're looking at the clinical workflow here. We found that the treatment duration for DIBH was typically 12 minutes, and we found that as the study went on and as the patient went on, those times decreased. So currently in 2016, we're using sorry, I don't mean to skip ahead, but also in this study, we looked at portal imaging for the weekly patient of the heart position in relation to the field. And we found that the mean uncertainty of the cardiac position was within 2 millimeters for these patients. So we found that the treatment times were acceptable and that the portal imaging showed us that the heart position was very stable as well for these patients. So clinically in 2016, we used a 15-minute time slot for our patients, and we found that works very well for our clinical process. So in the study I alluded to earlier of SPECT-SCAN, we had a protocol where left-sided breast cancer patients were put on a IRB-approved single-arm prospective study. In this, each patient received a pre-RT SPECT scan. We then planned the patient using tangential radiation therapy using our traditional field-and-field techniques with standard fractionation, either 25 fractions of 2 gray or Canadian fractionation. And we used Vision RT to track the surface of the patient to within 3 millimeters or 3 degrees for every fraction. To design the plan, we used DIBH and conformal blocking to make sure that the heart was always excluded from the radiation field. And 6 months after radiation therapy, we asked the patient to come back and receive a cardiac SPECT scan once again. And then our nuclear medicine physician team would then read the scan and tell us if there were any perfusion or motion defects noted from the SPECT scan themselves. So we found over a 20-patient cohort, we just completed left-sided DIBH RT with no perfusion scoring changes on any post-RT cardiac SPECT scans. So our results suggest that DIBH for left-sided breast cancer is an effective means to avoid SPECT cardiac perfusion defects. Here's a quick image at the bottom of what our nuke med physicians would look at, a coronal slice through the heart, and they would score various sectors of the heart to see if there's any abnormalities seen post-RT. So our study conclusions is that no perfusion defects were observed for DIBH patients on the study. I might have cut this out earlier, but an earlier study from UNC showed that for non-DIBH patients treated back in the 90s, they found a 27% rate of defect in the cardiac spec score 6 months post-RT. So we were going into the study expecting around 27% perfusion defects, but we found none. So we're considering continuing this protocol on to include MRI imaging instead of SPECT. And we've actually had patients call our clinic inquiring about DIBH. And so this is a fairly easy sell to patients, and people are actually seeking out this type of treatment when they hear about the cardiac sparing abilities of DIBH treatment. So in conclusions, for patients receiving left-sided breast cancer, we found that virtually all of our patients were able to be treated with ALIGN-RT DIBH. The DIBH is well tolerated by most breast cancer patients, and the mean dose to the heart can be reduced using these DIBH techniques. And cardiac avoidance with ALIGN-RT DIBH appears to be able to prevent abnormalities in the post-RT SPECT scans, and we hope, and then in turn, reduce the effect of cardiovascular disease down the road. So that concludes my talk. I'd love to take any questions. Yes?
So in your study, what's specific about vision RT that the other devices, similar devices such as an variance RPM system that cannot do? I mean, if you could comment a little bit on the technical aspect of vision RT, that'd be great.
I think it's one of the only systems out there that we used respiratory strain gauge belts in the past, and we've seen that there's a potential for misuse in terms of it doesn't interface with the machine. It was all a manual treatment, and like I alluded to earlier, depending on how tight that belt gets is what kind of signal you get out. So you can, if you're using such like a box placed on the patient's chest, they take in a breath, okay, they might be stable, but we don't know where they're stably at. They could be at a half breath position. They could be well overshooting what we had originally thought if this patient decided they were going to take a giant gulp of air in. So I think we need some sort of surface tracking to be sure that that surface is where we're at and not just some random position. Depending on where that marker box is placed, you would get a different reading every day when that patient takes in a breath.
Obviously, you want to put it in the same position every day, right, marker-wise?
Mm-hmm. You try to, but...
Right. But what is the sensitivity that you can detect in terms of rotation, or, what's called those three-angle rotations? Can you detect 1 degree rotation?
It should be. I think we have some speakers coming up that can attest to the tolerances of that, but at 1 degree, 1 millimeter would be what I would expect.
Okay.
Some other hands?
So you say virtually all left-sided breast cancer patients. What is the worst-case scenario?
Sometimes you have a very old lady that may not be good of hearing. Traditionally, all of our coaching has been through audio, through the actual intercom of the system of the therapist saying, take in a breath and hold it. So we're devising some devices to try to visually prompt them, but there's really nothing that we can do in our system. So if a lady is hard of hearing or doesn't want to comply, we've had a few patients like that, but once physics gets in there and talks to them and kind of coaches them through the process, pretty much every patient has been like that. And I asked the physician over the past 2 years, how many patients have you treated non-breath hold for left-sided? And he couldn't remember a patient that they hadn't at least tried to do so.
So you're finding out at the first day of treatment or the QA day. You're not finding out in the simulation process, right?
Yes, we don't have a Vision RT system installed in our sim to check that as well. So we're at least trying to match what they did that first day on the simulation. So it's really important that we coach them well to say, take in a deep breath, but not so deep you can't repeat it. So that's one of our instructions we give the sim therapist, is to make sure that they're coached well when they take that breath in and it's not uncomfortable to repeat, because they're going to have to do it 25 times again. Yeah.
How are you determining? Thank you. How are you determining whether or not that non-sim day, your first day in the accelerator vault, that they're in the same breath hold pattern, right? See what I mean? You have a pattern that you're only acquiring in the LINAC, but you didn't do it at the time of the DIBH scan. So how do you, are you just doing that through portal imaging?
So
or-
on the first day, they do get a portal image that the physician checks to make sure that they're in that position, and then we record the couch coordinates and make sure that those are within a tight tolerance of where we expect. And so that's pretty much the best way is to use portal imaging to verify that as well.
So during the CT simulation, are you doing a 4D CT or are you doing a deep inspiration breath hold CT where the CT scanner tells you to breathe in and hold your breath?
Just a complete breath hold scan, so they take in a deep breath and hold it as best we've coached them to do so.